Well, hello there everybody and welcome to Ovarian Cancer Australia's first webcast. My name's Anne-Marie Ferguson and I'm one of the coordinators of the support programme with Ovarian Cancer Australia. Before we begin this evening, I'd like to acknowledge the traditional owners of the land that we're standing on, the people of the Greater Kulin Nation, and I pay my respects to them, elders past and present. I would also like to acknowledge the Roche Foundation for funding this project. Today's webinar is on the theme of PARP inhibitors and ovarian cancer. The webinar is interactive, so please, I encourage you over the next hour to ask questions of the presenters. You'll be able to do that by typing into the chat box, which is located at the left-hand side of your screen. We're very eager to hear your questions. Your questions will be answered at the end of each presenter's speech. Please keep in mind that our presenters cannot address individual medical cases. If you have particular questions, you can call the Ovarian Cancer Australia support and information line. Also, if you're experiencing difficulty hearing the sound during the webinar, please dial the 1-800 number listed on the chat box. All right, so today we are very pleased to, welcome our presenters. Kristen Young is an ambassador for Ovarian Cancer Australia. Kristen was diagnosed with stage 3C ovarian cancer in 2009. After surgery and chemotherapy, she started her first clinical trial for maintenance with an anti-angiogenesis agent. She was also found to have the BRCA2 gene fault, and after a good remission, she relapsed in 2014. And after more surgery and chemotherapy, she started on the PARP inhibitor olaparib clinical trial, which she is on to this day. Johnathan Lederman, Professor Johnathan Lederman of Medical Oncology at UCL Cancer Institute and a consultant in medical oncology at UCL Hospitals, works in the Gynecological Cancer Centre. He's the clinical director of the UCL Cancer Institute and director of the Cancer Research UK and UCL Cancer Trial Centre, which is one of the national trials centres in the UK. Well, without further ado, I would like to pass us on to Professor Lederman to give his presentation this evening.
Thank you very much, Anne-Marie. It's a pleasure to be here in Australia, and I feel very honoured not only to have been invited to give this talk for Ovarian Cancer Australia, but actually to participate in the first webcast that you've done. So thank you for that. This is a picture of University College London, where I work. So what I'd like to do this evening is just to go over a little bit of the background of the poor prognosis that we have with current treatments of advanced ovarian cancer, and then talk a little bit about PARP inhibitors, the topic of tonight, and how these PARP inhibitors have developed and link their action to patients who carry this BRCA gene fault, and why this class of drugs is so active in women who have this BRCA gene fault. And then to discuss the results of the clinical trials that we had with PARP inhibitors that have led now to a new licensed treatment option for women with recurrent ovarian cancer. And then lastly, just to look a little bit into the future as to how these PARP inhibitors, I think, are going to develop further and give us greater opportunities for the treatment of ovarian cancer. So recurrent ovarian cancer is something that unfortunately most women with advanced ovarian cancer will experience at some time after they've had surgery and first-line chemotherapy. Now, many of these women will have a very good response to further treatments, but these are often of short duration. Chemotherapy has been the backbone of treatment for many years, but we give the same drugs to all patients without tailoring any of the treatments to the particular biological behavior of the tumor. And what we also know is with successive treatments, it becomes harder and harder to keep the disease under control. The responses become shorter as the tumors become more resistant to chemotherapy. So if we look at this schematically in a patient with recurrent ovarian cancer, and here I've listed the term platinum sensitive, which is what we use when the recurrence has occurred after an interval of more than 6 months. And these women will go on to chemotherapy for about 4.5 to 6 months, often have a very good response. And then we'll have a period of observation off treatment as they recover from the side effects of treatment and get back to normal life. But if you add these two sections together, it comes to about 8 to 10 months. And that's the average length of time before the next line of treatment is needed. And as time goes on, the tumors become more resistant to platinum chemotherapy. And although the treatment period remains reasonably constant, the time off treatment, the observation time, if you like, becomes shorter and shorter. So what we need to do is to try and lengthen these gaps between treatments, to lengthen these observation periods. And we need new treatments to do that. And those treatments need to be well tolerated so that patients' quality of life is maintained. And we need to develop these drugs that are specifically targeting patients who are most likely to benefit, not give them to all women in the hope that some will benefit. And that's what we call personalized medicine. So here you can see schematically lots of different patients, all colored differently. But only a few of those patients have a certain type of disease that will respond to a certain type of therapy, shown here in blue. So that's what we want to do. We want to pick out those women who are most likely to benefit from a drug, here a PARP inhibitor, and be able to give them that drug. So personalized medicine is using the right treatment at the right patient at the right time and the right dose, and that's what we've got to aim for. So if we look at PARP inhibitors, what are they? This is a sketch of our DNA, and all the time as we're sitting around this computer, we're getting breaks in our DNA, and you can see that schematically at the top of this cartoon. And that break is recognized by an enzyme, a chemical called PARP, and that binds to that break in the DNA and recruits in a number of other proteins that repair the damage and allow the DNA to become normal again and continue functioning and replicate. So what PARP inhibitors do is to inhibit that process, so that repair can't take place. So if you look at the bottom, you'll see again a little schema of the DNA. And PARP inhibitors work on these single-strand breaks of DNA. Now these normally are repaired unless you inhibit PARP. But what happens when you inhibit PARP is that you get these double-strand breaks of DNA, shown here with the 2 red circles. Now you can imagine these double strands are more serious because you've got to repair both ends to restore the DNA again. And this repair process takes place by a process called recombination repair. So if you block the PARP enzyme, you get the double-strand break that then is repaired by recombination therapy. But in women who have the gene fault in a BRCA protein, they can't produce the normal BRCA protein because they've got a fault in the gene, that recombination repair process can't work. And that's very serious for the cell because it can't repair itself and replicate, and so the cell here, the tumor cell, will die. So this is looking at it schematically. Look at the top. This is a normal tissue with a normal BRCA function. And the table legs here, there's one table leg that has the base excision repair, which is by PARP, and the other leg has this HR, homologous recombination repair, when you inhibit the PARP. So if you inhibit the PARP, you break one leg. But the table stands up because it's got the normal homologous recombination repair, and the table is stable. But at the lower graphs, lower section of the slide, you'll see that where you've already got damage to the repair process because of the BRCA deficiency, if you then block the base excision repair, the second leg breaks and the table falls, and that's tumor killing. So that's basically how PARP inhibitors work on tumor cells. And about 10 or 11 years ago, the first clinical trials started with a drug called olaparib in patients with BRCA mutated tumors. Many of these women had ovarian, some had breast cancer, and there were some men too who had prostate cancer and a BRCA mutation. What was remarkable about these studies was that 63%, almost 2/3 of these patients, had benefit from these early trials with olaparib. And what was also very interesting about these trials was that you can see in this graph at the bottom that the length of time, here the number of weeks, that patients remained well or responsive to these drugs was quite considerable. More than a year, more than 50 weeks in some of these patients. And these were patients who'd had lots and lots of treatment for their tumors. So it was immediately clear that this drug, olaparib, was active in patients with a BRCA mutation. And here on the right, you can see a CT scan showing the benefit in terms of the radiology in the two patients who had this drug olaparib for about 2 or 3 months. So within that period of time, these circled areas here, it's this tumor, you can see these getting smaller on olaparib. But we know that drugs like olaparib benefit more patients than just those with a BRCA mutation, because we know that this homologous recombination repair deficiency that I mentioned earlier is present perhaps in up to half the women with high-grade ovarian cancers. Now we know that the mutated gene, the faulty gene, is inherited in about 14% of women who have high-grade ovarian cancer. And another 6% of women don't inherit a fault of the gene, but they develop the fault within the tumor itself. So that leaves 20%. But we also know that there are another 30% of women who also have a tumor that has all the features of this homologous recombination deficiency. And when olaparib was tested in a wider group of patients with ovarian cancer, including women who did not have a BRCA mutation, we saw that the drug was active not only in patients with a BRCA mutation, but also in patients without a BRCA mutation. And you can see that here, the individual patients in each of these bars, and the ones in pink are the women who responded to olaparib, but did not have a BRCA gene fault. And on the left-hand side were a few patients who did not benefit at all. But most of these women responded, and many of these women did not have a BRCA mutation. So that's what led us to the trial, which has become known as Study 19, where we gave olaparib as maintenance therapy to patients with recurrent high-grade serous ovarian cancer that was responding to platinum. So in the trial, what we wanted to do was to look at what effect olaparib had on extending this period after chemotherapy that I showed you earlier on, so that women might have a longer period off treatment before the disease recurred and before they needed more chemotherapy. So 265 patients were entered into this trial across 16 countries in the world. And I'm now going to show you the results of that trial. They were randomized either to maintenance olaparib or a dummy tablet, a placebo tablet, and the measurements were made until the disease came back, and then the patients came off the trial. So what that showed was, on the left-hand side, this is what we call a survival curve. This is the time to disease progression. And those on olaparib had a much delayed time to progression compared to those on the placebo treatment. And you can see that separation of the curves represents the benefit, if you like, of giving that drug. And the extension here, a 3.6-month extension, additional time off treatment before the disease progressed. Now, in this trial, we had patients with a BRCA mutation, and we also had patients that did not have a BRCA mutation, as I showed you in that previous study. But what we did is look more closely at the women who had a BRCA mutation, and we saw an even bigger effect of olaparib in women that carried the BRCA gene fault. And here we can see that difference going from 4.3 months on average before the disease came back to 11.2 months. So that was a highly statistically significant difference. Recently, we've looked at the survival, the overall survival of these patients. We've been able to follow them up for many years, many more years, and we can see that there are trends in the improvement in survival in those patients taking olaparib. Here on the right-hand side, you can see that's an even greater difference in women who have this BRCA gene fault. And what also is strange about these survival curves is where I've shown this arrow, it seems to flatten off. So after about 3 years, the curve seems to flatten off. And I'm going to come back to that in a minute because I want to explain that in a little more detail. So what we now have is 6 years of follow-up of this trial. So the last patients went into this trial in 2010. And what we're seeing is that now 6 years later, there are still 11% of women who are receiving olaparib from this trial. 8 of these women have the BRCA mutation, but 7 of these women do not have a BRCA mutation. And there's 1 woman still receiving placebo tablets without any disease progression, but she has a BRCA mutation. So if we look at it on this bar chart below, these are the number of years that the patients on the trial have so far been on olaparib. And we take this point here of 5 or more years, you can see that overall 13% of the patients in this trial continue on olaparib without any evidence of recurrence of their disease 5 or more years later. And if we look at the patients who've got this gene fault, the BRCA gene fault, we can see it's 15%. So 15% of our patients with the BRCA gene fault are still taking the drug more than 5 years out with no recurrence of their tumor. And about 12% of the women who did not have a BRCA mutation, again, are taking this drug long term. And that's a really big new development for the treatment of recurrent ovarian cancer. And I'm just going to summarize those results schematically here. We measure this progression-free survival. That was our key differentiating measure, and as I showed you earlier, that's a 6.9-month difference and a small difference in the long-term survival in these patients. But I'd like to also draw your attention to something else that we looked at, which was not the time to progression, but the time before women had to start their next line of chemotherapy. And you can see that with olaparib, there was a 9.4-month extension in the time before the next line of chemotherapy was started. So these women were, on average, avoiding chemotherapy for an extra 9.4 months if they took olaparib. And we've very recently seen the results of a different PARP inhibitor studied in a very similar way. This is a drug called niraparib, which is not yet available in the sense that it's not got a license. And we see virtually the same results here in those women with a gene fault, the BRCA germline inherited gene fault, very big difference in the time to disease progression. And even those that don't have an inherited BRCA mutation, we see differences in favor of niraparib. So how well are these PARP inhibitors tolerated? Because if you're going to give a drug for a long period of time, it's important that women are able to manage this without too many side effects. So let's look in a moment at the key side effects of these drugs and talk a little bit about why we might need to modify the dose because of the key side effects, and to find out how many women discontinue the drug due to side effects. So these are all important considerations in assessing how well drugs are tolerated by women, and importantly, what is the quality of life on maintenance therapy. So we've looked at these things in considerable detail and really have been very pleased that the side effect profile has not been too severe. It's certainly nothing like chemotherapy. So for olaparib, the main side effects have been fatigue, nausea, and anemia, but they are generally of mild intensity. And the nausea is often short-lived and can be managed by interrupting the drugs for a couple of weeks and then starting the patients again. Sometimes you have to reduce the dose for side effects. About a quarter of patients in the trial needed a reduction in the dose of olaparib, but were able then to continue sometimes for several years. And only 6% of the women stopped the treatment early because of side effects. The niraparib drug, which is, as I said, not yet available, I'm sure will be licensed relatively soon. Again, fatigue is an issue. They have slightly different side effects. The blood platelet counts and white blood cell counts can go low, a little bit like on chemotherapy, and they can also get anemia, and some patients experience a raised blood pressure. But this low blood count often is early in the treatment, unlike chemotherapy where it often gets worse as the treatment goes on. And some patients will then need a reduction in the dose or occasionally stop, but most continue. And again, only 14% of these patients actually dropped out of the trial because of side effects. So the BRCA mutation here is key. And what we know is, of course, that in women who have a significant family history of breast and ovarian cancer, there's quite a high likelihood that they might carry the faulty gene. But we also know that many women who have tested positive when groups of women have been evaluated give no family history of breast or ovarian cancer. For example, the gene may have been passed through the father's line, and therefore no breast or ovarian cancer may have been seen. So about a third of women who are positive for a BRCA mutation give no family history. And that's very important for all of us, because what it means is that we need to test for a BRCA mutation even if there's no family history of breast or ovarian cancer. And so in England, where I work, we will now offer testing to all women who are diagnosed with ovarian cancer. We also know that in about 5 or 6%, the gene fault lies within the tumor, but not inherited. We call this somatic or tumor mutation. And that's important because the drug is as active in those patients as it is in those who have an inherited form of the cancer. The difficulty is that testing at the moment is quite complicated. Testing the tumors is quite complicated and expensive, and it's not routinely available. But it's something we have to think about as physicians and negotiate with those that pay for healthcare and discuss this issue with our patients. So just to draw to a conclusion, these PARP inhibitors have given us a new treatment for ovarian cancer as maintenance after platinum chemotherapy for patients with a faulty BRCA gene, a BRCA mutation. And we now have a license, and the license has recently been granted in Australia for olaparib. We see similar results with niraparib, but we're awaiting the full license of this drug. And we note that both these drugs also have an effect on patients who do not have the gene fault, sometimes called BRCA wild type, normal BRCA genes. At the moment, the license is not available for those patients, but it tells us that we do need to do more studies to try and extend the use of these drugs as much as we can. There are 2 more PARP inhibitors undergoing trials at the moment that are looking at a wider group of patients, and there are also clinical trials going on exploring the combination of PARP inhibitors with anti-angiogenic drugs, those drugs that inhibit the formation of new blood vessels that tumors need to grow. So all those trials are in progress, as indeed are trials with PARP inhibitors and the immunotherapy, the immune checkpoint inhibitors. So there's a lot of work going on at the moment to try and extend the treatment with PARP inhibitors. So to summarize, finally, PARP inhibitors are a new class of drug for the treatment of recurrent ovarian cancer, and the first group to have had a major impact on the disease for more than a decade. They're generally well tolerated and can be given for quite a prolonged period of time. And there are now opportunities to extend further and expand the use of PARP inhibitors as these new trials that I mentioned just now, the results of these new trials become available. Thank you very much.
That is just fantastic information, really clear. I very much appreciate it, Johnathan. Now, when we opened up for registration for this webcast, we invited participants to provide some questions. So if you don't mind, Johnathan, I'll pose a few questions to you that have come in during the registration process. The first question is, can PARP inhibitors be given a second time after being effective for 11 months?
So that's a very good and important question, and one I have to say at the moment that we don't know the answer to. So we do very much need to look at the possibility of retreating a patient with a PARP inhibitor at a later time after the first PARP inhibitor has been given. There are a number of different PARP inhibitors undergoing trials, and what we may find is that changing to a different PARP inhibitor may give a second response. But at the moment, I think we can't say for sure whether a patient will again respond to retreatment with a PARP inhibitor.
Thank you. Next question is, does PARP cause mutation of cancer cells and contribute to the chemo resistance of cancer cells?
Gosh, these are very very good questions. The answer is probably yes, but we don't know how much that's affecting further responses to treatment. So we do know that women who have a PARP inhibitor, in whom the PARP inhibitor works for a number of months or even years, who eventually then have a regrowth of their disease and go back onto chemotherapy. We know that many of those women will again respond to chemotherapy. But I think there is a question mark over the length of that response. And I think that we need to follow up these women for much longer to learn more about how PARP resistance, if you like, may affect the resistance to chemotherapy. So to answer the first part of your question, do the PARP inhibitors cause further mutations? They may do, but I think in the end what we need to look at is the overall benefit of a PARP inhibitor. So going back to my very early slide showing you this really short period, relatively short period of freedom from further treatment, by extending that significantly, we actually extend the survival of women overall, and of course that's what we really want to do.
Fantastic. All right. Next question coming your way, and it might be located within the Australian context, is how many women in Australia are currently taking olaparib?
I can't.
Yes,
thank you. I don't really think I can really answer that question. I mean, what I do know from the few days that I've been here is that there is an expanded access program, and I think that women in Australia are able to access the drug through that program. And at the moment, as far as I'm aware, there's not general reimbursement for the drug, but that's being considered at the moment.
Indeed it is. That was a question from Gail. Hello, Gail. Please feel free to give Ovarian Cancer Australia a call, and we'll do our best to come up with some information around that for you. Next question. I'm currently receiving olaparib compassionately. Will this continue again? Johnathan, this might be out of your scope because it's Australia.
From what I understand, from the little time I've been here and talking to colleagues, I think that when patients are on the expanded access program, they will continue to have it until the health payers in this country agree to pay for it, in which case I guess patients will then transfer over to that. So I don't think there's any danger that patients on this program will come off the drug purely for financial or administrative reasons. It will only come off if it's not working or if they have side effects that can't be easily managed.
Thank you. A question, if I have already had failure on olaparib and I'm BRCA2 positive, what does this mean with other PARPs? Will they also fail?
Well, we don't know as to whether or not re-challenge with different PARP inhibitors is going to be effective in this situation. At the moment, olaparib is the only licensed one, and if that's the drug that you've had, then it will be difficult to access another PARP inhibitor unless it's a clinical trial that's specifically looking at retreatment of patients. So those trials are beginning. I don't know whether they're open here in Australia. They're just beginning, perhaps not on their own, but in combination with other new drugs. So I think it's worth just keeping a lookout to see if those trials are available.
That's a really good segue into the next question, which asks is it possible to join a clinical trial from another country?
That is generally quite difficult, and we've had this even within Europe, where patients, have tried to sort of move from one provider to another. It's not impossible, but it is quite difficult. These trials require often very frequent hospital visits, and those visits have to be in the hospital where the trial is taking place. So that means effectively being in that country for a long period of time, and that can be quite a difficult thing to do. So generally speaking, the answer is no.
Question asks is about the suitability for women without the fault in the BRCA mutation, without the fault in the BRCA.
Yes. So at the moment, the license and therefore the expanded access program covers only women who have the gene fault. But we know from the clinical trial that some women without that gene fault had a very good effect from the drug. So I think we really need to some women without that gene fault had a very good effect from the drug. So I think we really need to get into greater detail of understanding that so that we can, I hope, expand the opportunities to use these drugs in those women without the gene fault. So I showed you the results of the niraparib trial, which included women without the gene fault. There's the other ongoing trial with rucaparib, another PARP inhibitor. So I think if these come together and they consistently show that a certain proportion of women without the gene fault benefit, then I think there's a hope that we can see the drug licensed in a broader group of women so that it's more freely available to them.
Two more questions, Johnathan. What's coming in the future? Options to olaparib?
So I think the next big step is going to be combining olaparib or PARP inhibitors, but here olaparib, with other drugs. And here I just will make a little plug for an international trial that will open in Australia. It's called the ICON-9 trial that we're running from the UK, but in collaboration with ANSCOM. And that will combine olaparib with an oral tablet called cediranib, which is a drug that inhibits the growth of tumor blood vessels. So actually, by joining that trial, all patients will get olaparib, even without gene fault, and half of them will in addition get maintenance of cediranib. So we're hoping that trial will open in the second or third quarter of next year.
Well, as you can imagine, the Ovarian Cancer Australia support line is going to be inundated with telephone calls asking for more information about that. So I would just like to reassure people that we will get further information from Professor Lederman and make that available to everyone. Our final question, which will segue into our next guest speaker. The question asks, is there a way to reduce the fatigue caused by olaparib? And what is the minimum effective dose of olaparib?
These are both very, very good questions. Fatigue, of course, is a very variable symptom. For some people, for some patients, fatigue can be debilitating. For others, it's just a bit of a nuisance. And so we see this spectrum with olaparib too. It seems that in many women, the fatigue comes in the first 2 to 3 months and then fades spontaneously, or we just give a patient a break for 2 weeks and then restart treatment and they seem to continue without the fatigue. Occasionally, we reduce the dose of the drug and then they can continue without the fatigue. So what effect then does, which was the second part of your question, does reducing the dose have on the treatment? The dose that we use is what's called a flat dose. It's the same dose for all women, different sizes, ages, no consideration at all for the way in which we all metabolize our drugs, which is differently. So for some women, the dose of 400 twice daily is too much. And by reducing it to 200, their body not only copes better with it, but it has an effect on the tumor, which, as far as we can tell, is as good as those women taking the higher dose. So we don't seem to compromise effectiveness by reducing the dose in those women that need a dose reduction. That's not to say that everybody should have a dose reduction, because some women may need a higher dose because they break down the drug more quickly. So I think what we should be aware of is tailoring the treatment to the symptoms, and where we can't manage the symptoms, or a patient can't manage the symptoms by having this pause in treatment, then the next step is to reduce the dose. But going back to the trial, only 6% of the women stopped treatment because of side effects. So most of the women, either with dose interruptions or dose reductions, can continue the treatment. And as you saw, about 15% of the women with a BRCA gene fault were taking the drug for more than 5 years continuously.
Thank you so very much. I'm sure I'm speaking on behalf of many of the women who are listening today, Johnathan, that your information, the women are greedy for this information, and I really appreciate you taking the time to do it.